but we have to go back because I didn't talk about the closed and loose pack positions. I think I jumped the slide. But let's say that I'm doing, oh, it matched. Right there, okay? I have Patrick, and Patrick had a knee surgery, maybe a knee replacement, and after a certain period of time, I'm going to start working to increase motion for the knee. If I have a femur that is stable, and I'm going to use the forces of distraction in gliding to increase range of motion, which part is concave, which part is convex? The tibia or the femur? Concave. Tibia. So if I'm going to increase knee flexion with this patient, I want to increase knee flexion. As a physical therapist, where do you think is my force applied? Posterior or anterior? I can do this, or I can do this.
Anterior.
Anterior?
Yeah.
If I do anterior, I'm going to pull the force up this way.
Oh,
So if I do anterior, it goes to the same direction of the motion, right, of the body segment. Yes? I have it here, and I try to pull this up. It's going to increase my extension component.
So posterior.
So I need to go posterior. What I do is that I go close to the joint line where the tibia is. I stabilize my femur. And again, don't go crazy. Just get the concept. Because by law, you're not allowed to do this. Because it's increasing range of motion right now. So I have my femur stable. And what I'm going to do is I'm going to apply oscillations, very gentle oscillations, kind of mid-range and the end of the range. And this is what I do. Can Patrick stop that?
Yes.
Yes, he can. Can you stop me?
Yeah, I can kick up.
Yeah, he can. This is not manipulation. This is joint mobilization.
Oh, yeah.
Yes, I could do also, let's say that he has arthritis, osteoarthritis in the knee. And what is osteoarthritis again? What happens?
Degeneration.
Degeneration. And I see basically that instead of having a nice space, joint space, I have a decreased joint space, and they're usually robbing. Once they need, as an example, a total knee replacement is because the cartilage is really already damaged. So what I do is, then to decrease pain, because it's going into surgery, maybe I'll do some type relax. My patient has to be relaxed. And maybe I attempt to do a distraction force. So those are simple techniques. This is not because we want you to know concave convex rule. There's a purpose, and they're called joint modes, okay? So try gently, get a bolster or roll up a big towel, put it underneath your classmate, and try to see if you can successfully mobilize your joint, and you can feel how much he can give out of his end, okay? Also, we're going to talk about closed back and open back positions. If I have, we'll go through the slides in a minute, open back positions, I can move the patella, okay? Now I'm going to ask, or I'm going to just place Patrick in knee flexion, right there. It's almost impossible for me to move the patella. It's not going to move. It's a closed back position. Okay? A closed back position, I'm going to be able to test for integrity because my ligaments and the capsules are going to be taut in the joint area. So for me to know if the ACL is intact and I don't have a tear or some give, instability, what I do is not going to match with the book description of closed back position. What's that?
Don't stand too close to his feet. You might pass out.
Oh, Patrick. Listen, I have 20 years of experience, and believe me, if I smell something, you're in trouble. I don't smell anything right now. You're good.
Nick, do you smell it?
You're all right.
Okay, so if I'm going to test for joint instability, what I do is I usually determine the book is usually go to my closed back position. The closed pack position is the position where your patient usually gets injured. How they get injured, closed pack position, okay? And we'll see when we go to the knee. If I'm going to test for the anterior cruciate ligament, I can do a couple tests. I can do the Lachman's test, which is basically your closed pack position, like 20-30 degrees of knee flexion. But the anterior door test is done at 90 degrees. So what I do is, and this you don't need to know. This is nice to know right now so that you can remember. I stabilize and I pull. Okay, I do a force to see how and I compare to the other side how much give. He should have some. This is right. He should have some. Now, if I pull on Patrick, and all of a sudden I see that coming really out, and it feels unstable. What kind of infill is that then?
Empty.
Empty infill. Okay. So go ahead and go supine and try to do your posterior force with the tibia. Relax. And try to see if you can feel how much it gives. Okay.
Can we use this one?
Go ahead.